Good morning, everyone, and welcome to the Market Access Summit. My name is Elias Eliopoulos, and I am the head of payer engagement and strategic partnerships team at AstraZeneca Canada. And I am honored to be moderating this panel on the private payer market today. The private insurance has and continues to play a critical role in supporting the health and wellness, and as well as improving the productivity of working Canadians. Canada ranks almost last amongst OECD countries in time to public access to innovative medicines, and private insurers provide a significant value to patients in the form of faster and broader access to innovative therapies. This type of access helps to support workplace productivity, reduce absenteeism, and improve presenteeism. But importantly, it is also a key benefit to attract and retain employees. I'm joined today by a group of experts in this space to delve into the evolution of the private payer market, its broader impacts on our industries, and the potential effect on access to innovative therapies. Our panelists bring a wealth of knowledge and expertise to the table, and I'm confident that our conversation will be both insightful and thought-provoking. We will discuss a number of areas and then open the floor to the audience to ask any questions of our panelists. Let's meet our panel. So Bobby Currie is the Director of Drug Evaluation with Manulife. Martin Chung is Assistant Vice President of Strategic Health Management at Equitable Life Canada. And David Greiss is Director of Pharmaceutical Partnerships and Operations at Green Shield Canada. Now, each of them bring a depth and breadth of understanding in their current roles and current respective markets, but they also bring a unique perspective in their previous roles. Some on the public side, some in the pharmaceutical industry. So we're really looking forward to getting your insights and thoughts on this important topic. So let's get started. So given the current and evolving healthcare environment, could you please provide us with your perspective on the impact that it is having on private payers? And maybe, Bobby, I'll start with you.
Sure. I think this is kind of the core question of this panel. What's happening in the private space that impacts all of you and the way that you interact with us? The challenge is that it's not just what's happening in the private space. One of the things that I think is underappreciated is that the global healthcare system pressures are creating more and more pressures on private plans. So when we have doctor shortages, when we have challenges in the public healthcare system, that's putting more pressure on private plans to fill some gaps. And I think it's really important that we're there to help fill those gaps, but it does raise a lot of questions around cost, and our plan sponsors are seeing rates increase year over year over year, and they're really worried about sustainability. So that's something that we are always thinking about, whether we're talking about the drug plan or any other part of the group benefit space. How do we make this sustainable? How do we make sure that we're there for people when they need us? And I think that's kind of one of the main themes of our discussions recently has been focused on that sustainability piece.
Thank you for that, Bobby. David?
Yeah, thanks for having me. Good morning, everyone. I think drugs in general tend to be a very fast and evolving space, which is maybe the exact opposite of how insurance companies tend to work. But you can imagine that, I would say, over the last 10 or 15 years, the pipeline of drugs that have come to market and the sheer volume of drugs that have come to market are radically different than what we would have seen 20 or 30 years ago. And it's really forcing insurance carriers to think about the drug space differently. How do we interact with the pharmaceutical industry as a whole? And what really is our role, within Canada, within the healthcare industry, that we provide, yes, a benefits package. We have clients that are plan sponsors who are the ultimate payer, and we have a responsibility of ultimately using their money wisely. And so what you've typically seen is sort of like this movement around sustainability and management around the drug plan as it continues to be kind of a growing cost and somewhat of a concern relative to the broader economic climate.
Martin?
Good morning. I'm going to respond to that by taking a bit of a step back and not really talking about the private payer side, but what the overall healthcare landscape looks like that impacts us. So I think there's about, I don't know, maybe 3-5 things. Number one, well, we have a lot of orphan patients who don't even have a family doctor. You may be wondering, well, how does that impact us? Well, it impacts us and all of us because we don't have early diagnosis. We don't have early intervention. And the notion of prevention that's been discussed for as long as I've come out of university, in reality, is not very well delivered. We have a fragmented healthcare system. I'm going through, like many of you, quite an interesting journey with my mother, who has unfortunately come down with some more serious conditions. What a peach it is to navigate the healthcare system, eh, folks? Right? We're all in it, but you don't truly know it until you're actually in it. You know what I mean? It's a mess. In Ontario, the nature of the waiting list, especially for certain conditions and so on, that ultimately trickles down to Canadians. It ultimately trickles down to insurers and employers. Lastly, we have this great 5-generation divide. We now have 5 generations working in the workforce. The government in general does not really focus on all 5 generations with respect to healthcare strategy. We, as insurers and employers, however, have to. Do you think a Gen Z has a few different perspectives on priorities versus a baby boomer? Yeah. In fact, we've done a lot of deep analysis on that. And we have to recognize as well that retention, as much as you hear that benefits are a key part of retention, the reality is, especially among Gen X and Gen Z, do you know what the turnover rate is? Even, they're not let go. They just move on to other opportunities. That has huge implications for government as well as for insurers. I'm going to take a step back in that regard because I suspect you'll have more specific questions on what's on the private payer side, but this is challenging all of us in health prevention as well as intervention affordability.
Okay. Thank you for that, Martin. And thank you for all your perspectives on that and really opening up the discussion. So I mentioned earlier on that access to innovative medicines really continues to be a challenge. As I said, we're amongst the lowest. I think we're 18th or 19th out of 20 OECD countries in terms of public or access to innovative therapies on the public side. You know, again, private plans do play that critical role in really ensuring that patients working Canadian patients have access to these innovative medicines. But more recently, we have seen delays, and we have seen more restrictions to access to innovative therapies on the private side. And it is heterogeneous in terms of what those kind of delays are. Could you take us through what's contributing to those? Martin, I'll start with you.
The first thing is I'm going to strongly encourage you to do your best to think beyond drugs. You think the average employer, every one of you is a plan member at your respective company. You are a plan member of an insurance program. Is drugs the only thing you think about and worry about as a plan member? Do you think your employer only worries about drugs? Folks, what we have unfolding post-COVID is we have the potential in 2025, and we know this is likely coming, and is why what you're seeing, some of what your comments were, such as, do you have any awareness the scale of inflation and paramedical benefit costs in the last 2 years? Do you have any idea of the scale of the dental benefit inflation in the last 2 years? Do you know that last year was the year of the super surge in drug inflation? In other words, ultimate decision makers and those who ultimately fund private drug plans and private benefits, drugs make up, it is one of the biggest costs, but by no means is it the sole cost. disability trends are starting to change back to more historical norms, which means disability costs are going up. Has your benefit plan changed a little bit over the last 5 years? Our clients are no different. Now, on top of all that, we've had for the last 10 years, high-cost drugs over 10,000 or so, has been, of course, a great area of concern and ongoing. But if you understand how the money flows and how the financials work in real life, in insurance, when we now start, in addition to that, having drugs which cost $1,000, $2,000, $3,000, $4,000 a year, and there's an awful lot of them. Who owns that risk, folks? The short answer is it's the employer. For a $100,000 drug, there's a shared risk in a variety of ways, as you may know, that it's ultimately funded, and some of it is pooled, and so on and so on. So, to answer your question, why are we saying this? Part of it is private payers have realized that the bar for a drug to be approved in Health Canada is a critical step, but by no means does it mean that, okay, this drug is effective, safe, and furthermore, it's probably more effective than 5, 6, 7 other lower-cost options already on the market. It's the fundamental dilemma that exists with payers. Public plans, for years, have not covered all kinds of new drugs or new indications. We as private payers, frankly, have been your golden goose that kept laying the golden egg. Those times are no longer, folks. This trend will continue because we have clients who are really struggling with affordability. Now, what's interesting, my last point, is you also have to remember that 2/3 of working Canadians, those with a employer-funded benefit program, work for small, mid-sized companies. What you see in most articles and conferences is a perspective on what's going on with large employers who only employ 1/3 of Canadians. The small mid-market is a completely different animal. And your question is a good one. But the one gap in that question is you're suggesting that there's drugs that are not being covered as quickly, perhaps, as before. But what you should really care about equally more, or as much, is how much is it being covered? Please stop calling us and saying what percentage of your plans are open. Because it is an irrelevant question. There is no such thing today as a truly open plan. I could tell you 70, 80% are open. But then when I tell you what the percentage of them have an annual maximum, and you're about to launch a $30,000 drug, are you still excited that most plans are open?
So maybe before we go to David and Bobby, I'd like to explore that a little bit more, Martin, because you said something that's quite interesting, and I think for many of us here in the room, you know, we've always talked about the impact of drugs on other parts of the healthcare system. When we look on the public side, what are the downstream ramifications on the healthcare system and the ultimate impact on resource utilization? You mentioned the other spends. How aware are plan sponsors of the impact it has on other parts of their business, on short-term disability, on long-term disability, on the paramedical spends? How is that being linked? Because as we all understand it, and I understand it, it's similar to what we see on the public side, where it is a very siloed approach sometimes. Mm-hmm. What are private payers doing to break down that barrier of understanding of drug spend and impact on healthcare system or systemic use or costs?
I'll give a much shorter answer this time. One, in active disability case management, really well. Because when there's an active disability case, we are privy and are required to know all the other moving parts: physicians, lab, surgeries, drugs, paramedical, and so on. Partly because we want to make sure they have what they need to manage and overcome their disability. On the non-disability side, we have a long ways to go, as does the public healthcare system. Good news, though. many insurers and advisor firms and other firms as well are investing millions of dollars, I know we are, to take technology and database and analytics and modeling and ideally predictive modeling to a whole other level. We have a long ways to go, but you also have to remember, because of PIPEDA and other things, we are also unfortunately greatly limited in this full scale of data that we can or should or need to know. But we're making the links, and we've already done some things, but I'm encouraged by that.
Okay, excellent, thank you. David, any additional thoughts on this?
I mean, it's hard to add more to sort of what Martin's been saying. I guess just from my perspective, I guess, and maybe at risk of oversimplifying it, but making formulary listing decisions is a lot harder than what it used to be, and there's a lot more considerations that need to be considered. As I mentioned, like, we're moving away from drugs that are costing $600 a year, $1,000 a year, to tens of thousands, hundreds of thousands, and in some cases, exceeding that. And so, obviously, the decision carries a lot more considerations. What it means for, let's take the example of a small employer to be hit with a pretty significant, one patient that costs over $100,000 or something, has significant consequences as a result of that. So I think, gone are the days where NOC is, the ticket to listings. There's a lot more rigor, I'll say, and thought that goes into sort of what gets listed. As Martin said, that the concept of an open plan is somewhat archaic, I think, or at least needs a revision of how we think about it, because even open plans used to mean like no prior authorization, for example, and even that seems to be not the case across the board. Neither are there expectations with the plan sponsors who have open plans that there will be no cost controls in place. So, so I guess that's sort of my perspective of things, that these things aren't so simple. And the intent is not to slow down listing just for the sake of it, is that we need to be a little bit more thoughtful and careful. And we have teams of people now looking at each individual drug as, as it enters the marketplace.
Okay. Excellent. Bobby, anything to add on that?
A couple things. I think we've touched a lot on why we need to do more due diligence, right? Why we're looking harder at these new drug launches. Ultimately, we do have to have a responsibility and accountability back to plan sponsors who are funding these drugs. The model's a little different in private than it is in public, where, we have products that we have to go out and convince plan sponsors to purchase. As we mentioned, the open benefit plans still are on that product shelf. They're just not being chosen anymore because they're too expensive, and there's that sustainability, affordability question from our plan sponsors. So the why we're doing more due diligence, why there's more work being done on these new launches, I think just comes back to that plan sponsor value piece. And Elias, to your question about what are we doing to demonstrate or link that value, one, I would also look to all of you in this room that are putting together submission packages. If that data is out there, we'd love to see it. We just saw a real-world evidence panel talking about that, and I'm hopeful that we can get more value-based evidence to be able to report back on, why this investment in drugs makes sense for private payers. Being able to demonstrate those things back to our sponsors can prove a lot of value in our products. And that's part, I think, of this general theme of understanding the business models that we're all working within. If you can understand those things, we can have a lot more open dialogue, have that collaborative kind of discussion about how we can make a product work for our drug plans.
Okay, excellent, thank you. So on drug submissions, and I know there are just maybe one or two people here in the room that are interested in drug submissions to private payers, what are some of the refinements that are being made to the requirements for drug submissions, and what should manufacturers be aware of? Anyone? Yeah,
I'll
go ahead,
for it.
Bobby.
No, go
I
ahead.
can start. I mean, I think drug submissions to me, and I mean, I've been working with drug submissions for quite a while. There's parts of them that are sort of table stakes, right? You know, we all know that you have to have your clinical trials laid out. Most insurers are going to have a list of things that you need to be including. What's evolving to me is these discussions around the softer elements, the more subjective elements, value to a workplace, for example. We talk a lot about absenteeism and presenteeism. That doesn't show up in the clinical trials very often. So it's a tough one for us to properly evaluate. But I think, to me, that's part of that evolution, is figuring out ways to bring that subjective into the discussions that we're having, into the evaluations that we're doing appropriately. We want that value to be represented in our plans when we can, but if we had, you know, the more ways to measure it, I think that we could do a lot better job in demonstrating value back to sponsors and strengthening that rationale around choosing more of a managed approach instead of that sledgehammer approach with hard caps. That's really something I think a lot of us are trying to avoid. It's not the most elegant solution to the cost pressures that our sponsors are facing, and unfortunately, it's the easy one. Just put a cap on, and that's not where we all want to land.
No, definitely not. Okay. David. Oh, sorry, Mark.
No, go ahead, Dave.
I guess, just to build on Bobby's point, is I think it's important to keep in mind, like, we'll do, 8 to 10 drug submissions a month for new branded products, right? And so from your perspective, I can imagine, like, you understand the product so well, you may even understand the value prop, but on our side, it's important for us to understand your value prop as well, because ultimately we need to communicate that either to our stakeholders and also sort of like typically a clinical team that will ultimately make a final decision. So yes, there's the clinical piece as well, but if, from my perspective, it's really showing us what is the value prop, how does this fit into the private payer market, and is it sufficient that a new formulation or a new mechanism of action, how does that even translate into value for our clients? Because we are often either audited or being asked to answer our formulary decisions as well. So we have to have a strong foundation and a basis as to sort of why we are listing things the way we are. So that would be kind of the piece. I mean, there's obviously table stakes when it comes to the requirements and whatnot, and I presume that those are more or less standard, but I would say, when we look at it, remember, we're seeing a huge volume of these. We don't know the product as well as you do, and then really communicating your value prop is important.
The core parts of submissions haven't changed much in terms of what the table of contents need to be. So I would encourage you to continue to do that and keep it fairly brief and keep it as private payer specific as possible. Now, where are the gaps? Where are the areas that many of us marvel in terms of what's missing or not being at least acknowledged? Do you agree that we are kind of in a unique convergence of stuff right now? And what I mean by that, for about 10 years or so, we've had high-cost drugs coming onto the market. And we are about to we've started entering a new era of new drugs coming to market where a whack of them are just thousands a year instead of tens and hundreds of thousands a year. And on top of that, you all know the typical drug life cycle. By as early as year 2, but typically year 3, 4, 5, and 6, what happens to every new drug that already is on the market? Not every new drug, but a lot of them. A whole bunch of new indications. So we now are in an era where we have not one, not two, but a lot more than that, high-cost drugs for, can I mention disease names?
Sure.
Yeah, why not, right? Atopic dermatitis. Yeah. And I could ream off many other buckets of drugs where we now have not just a new first-time entrant high-cost drug. We also now have drugs that only cost $1,000, $2,000, first-time drugs for certain other common conditions. What we have, folks, is a convergence of new indications for more and more common conditions for both drugs that cost thousands and tens of thousands. What does that mean for submission? Maybe acknowledge that. And what I mean by that is, sorry, don't have any head-to-head trials as usual to compare us to the 5 others already on the market. Acknowledge it. It'll go a long way. If you have some reasonable degree of fact-based data that can say, well, however, there are some indications that our drug may be different because of that. Maybe your pricing strategy is different. That alone is obviously important to highlight. And nowadays, I don't know about you guys, I really love a good, in the old days, I really did not like cover letters. Now I really love cover letters. Because in the past, cover letters never said anything that isn't already in the submission. But nowadays, I think the cover letter needs to say, hey, attached is detailed information for your review. Great. Here's what we view, payer, as what we'd like to see as next steps. We've made a submission to you. Tick. Awesome. We would like to have, if the timing makes sense, a pre-NOC meeting. We like to have some type of partnership meeting recognizing before you make a decision. Do you get what I'm saying? Lay out your desired roadmap. Doesn't mean we're going to agree to it, but lay it out. That, to me, constitutes not a data dump, but a thoughtful recognition that we recognize as a key decision maker and a customer, and we also need to explain things to our clients who are struggling with what they can afford, and it lays out, okay, here's something that this company is willing to do. To manage expectations, this is not going to matter for every single drug that comes on the market, but you all know if you're about to launch either a higher profile drug or if you're about to launch a drug that's already in the market with a new indication that is going to be of importance. Does that make sense? That little cover page that says, here's what we propose as how we approach this.
Bobby, I think you have something else?
Yeah, I just want to follow up to that if I can. Just one more piece of advice. When you're bringing a submission forward to us, we are your partners in getting that listed, and sometimes it can feel that we're viewed as a roadblock or this adversary, which isn't as productive as when we can have that open conversation to say, here's my roadblocks, here's your roadblocks, and then we can work on them together. So I think Martin really alluded to some of that, by being curious about where the challenges are coming from on both sides. We can brainstorm, we can problem solve a little bit more efficiently when there's a lack of transparency in that conversation, or if there's a sense that, a worry that sharing information is going to hold things up or get us to reject your drug. That's just not the case. We're looking for ways to make it work. That's our goal. We have customers that want to see things listed just at a globally sustainable and affordable place in the therapies. So that would be my request. Come to collaborate.
All right. Thank you, Bobby. So I'm going to ask my last question, then we're going to open it up to the audience as well. I know that we already have a virtual question coming through. I think I want to touch a little bit on national pharmacare, and not national pharmacare itself, but the implications national pharmacare has on the unique interplay between the public and private reimbursement of therapies. How are you preparing and planning for really a complex scenario where you have unique and heterogeneous environments in each of the provincial jurisdictions, different criteria, different coverage, different products, yet you may have plans that cross over each of these jurisdictions. How are you planning for that and preparing, and what are the potential implications?
Well, I would just say,
Sir?
A, technology. Two, we're basically, I think several carriers are basically ready today, if they really had to, manage these nuances that you mentioned. And FYI, we manage those nuances already today.
Of course, of course.
Not necessarily because of a national pharmacare, but because of other programs. And so I don't think in terms of that specific question, I, for one, am not too terribly concerned.
Okay. David?
Yeah, I mean, obviously we're monitoring the space very closely, I'm sure as you are. I think in general, private payers feel that they have a place to play in Canada when it comes to drugs and providing access to care. I think the jury's still out sort of what type of impact it'll have really on the private payer space. I think we continue to kind of work with governments. We have our associations also working at the different levels of government to really understand sort of what the impact is and really what is the role that they even see us playing here. Because I think there needs to be more of a dialogue, I think, as with respect to sort of where Canada is as we're all Canadians, and what does that mean for what is the benefit and what we're trying to do here for ultimately for patients. So I agree with Martin. Like the logistics, I think can be easily sorted out. We integrate with a whole variety of plans, public plans and otherwise. So it's less about the logistics. It's more to say like where is the policy going to land? I would say is the bigger questions, which we're still waiting, I think, to see where those.
Okay. Bobby, I'll give you closing remarks, and then we'll move to audience questions.
Well, essentially, I agree. I think that there's a lot of uncertainty in the pharmacare space. We're all preparing for it, and the fundamental logistics underneath are there, regardless of where we end up. So it's an evolving situation, and it's certainly a hot topic, but it's not one that is going to be resolved right away.
Okay, excellent. Thank you. And thank you all for your insights, thoughts. I'm going to turn it now to the audience. I can see some parts of the room, but other parts I can't, so please put up your hand if you have any questions. But I think we already have one question online, so I'll go to that question first. So question is according to a TELUS report, current annual drug plan maximums capped at 10,000 have hit 33% of drug plans. If 1/3 of private plan members do not have access to newer innovative drugs due to these caps, which help control premium costs, do you see a role for governments to introduce a legislation to support these employers to manage the premiums? Anyone want to take this one?
What an interesting question, and a very good one. And the end of that, by the way, can you all see the question on your screens? Oh,
No? Okay. So,
All right.
there you go.
The last part reminds me of something that I think is so important and yet not in place. You guys, most of you make a real important point of making sure you understand all the nuances of how things flow through policy development decisions in various provincial, federal governments. How much do you understand about how things really work in managing affordability and how group benefits and drug plans are even funded in Canada? That's going to be really important, because that last piece of that question, where there's a reference to premiums, is not that easy to answer unless you know how the insurance world actually works. But that aside, the front end of the question is a very interesting one, and the reason is, this is one of my biggest concerns, that especially in the small, mid-sized market, like there aren't too many mega large employers that have an annual drug maximum. Can you think of one that does? Where it is the most prevalent is in that 2/3 of Canadians who work in the small, mid-sized market. They're actually your most important, because they also tend to have, believe it or not, some of the relatively more generous drug plans compared to the larger employers. Providing access to drugs without making sure we partner on affordability will result in this trend, the 33%, whether that's the real number, a bit higher, a bit lower, will continue. And I know that may sound odd. One of the reasons I am quite supportive of private payers evolving and partnering smarter and differently for mutual value with the pharmaceutical industry is so that we can slow down the number of employers who don't really understand. They are not experts in benefit management, never mind drug management, never mind an individual drug. So their often easier solution is, wow, I have a really difficult renewal. I think it's time for me to put in an annual drug max. And that doesn't just impact one of you, that impacts a lot of you. But each and every one of you, if we partner more effectively, and maybe approach us kind of like you would approach public plans with the due diligence and flexibility and openness for reasonable partnerships, instead of presuming we're going to be there for you. Because this one is a great question because it is becoming even more prevalent.
So maybe a question to you. What is the private industry doing to raise or create better awareness of the impact of these types of decisions by plan sponsors and plan members? Because we often hear, I wasn't aware that that had an impact.
Yeah.
We often get patients that come through our patient support programs that thought, I have private insurance, yet I didn't realize I can only spend $1,000 a year. So what are they doing to create and raise awareness to ensure that their decision-making is fully informed?
I think the most important part is, not all, but the vast majority of employers are attached to an advisor or a benefit consultant. Mm-hmm. And since we, as insurers, work a lot with them, that's definitely one of our first stakeholders that we want to make sure that we provide them as practical and relevant insights as possible, mm-hmm. as well as some options if they happen to have a client who are in a certain situation versus another client where, look, cost is not a barrier for me. I am desperate to keep my employees, so just leave my benefit plan alone. Because there's all different kinds of employers out there. That's number one. For certain size of employers, it's worth making sure that they understand the reality of what's going on. But I hope you can understand the average owner of a company with 50 employees, who's the VP of HR, marketing, business strategy, and the head accountant and finance all in one person, they're not the person necessarily because they frankly don't always have the time or the ability.
Okay, thank you. Any other questions in the audience? We have about 5 minutes left. Ooh.
I can add a
Yeah, you want to add a little bit,
of
Bobby?
a point to
Yeah,
that
gentleman
one.
down there.
Or I can't see. I'm like right in the light.
There's one.
It's on this time. Okay. Guess a couple of questions just in the context of industry spending in general. So from a pharmaceutical spending perspective in Canada, we have had a very consistent cost per capita for a long time. So sustainability-wise, I would say we don't have a sustainability problem. So I'm always puzzled why the private market, and without being adversarial here, because I do want to be a partner, why we say we have a problem. I recently investigated plan pooling quite a bit, and I think the real problem here is a distribution of risk and a failure of the insurance industry to distribute risk for plan sponsors effectively. From a broader perspective, we're implementing plan maximums, which is helping plan sponsors manage risk in a really simple, decision-based way. Unfortunately, it's leaving people that need innovative medicines out, particularly in Ontario and the Atlantic provinces. When you look at the West, it's fine. They have ways to get access to the public system pretty quickly. But in Ontario and the Atlantic, we don't have that. In Quebec, the insurance industry is regulated. They are told you must provide insurance that is similar to Quebec across the board. We don't hear the sustainability problem in Quebec, but we hear it here in Ontario. Now we see 30% of plans having plan maximums, particularly in the small to mid-sized market. Why would we negotiate as an industry, negotiate with private payers when most of the plan members that are being covered by your plans won't actually benefit from the medicine we're trying to get on your formulary?
If you look at drug as you say, per capita and other metrics in isolation, depending on which data source you're looking at, I suppose I could agree with you. But I remind you yet again, the overall health group benefit program spend that the average employer has, the drugs don't make up even half of that. Back to my very earlier comment, sir, we have tremendous challenges when we have all these other benefits that in combination are far more than drugs. When that starts to happen, clients have to say, where can I reasonably afford to maybe make some tweaks in my plan? Mm-hmm. They may increase or reduce your paramedical per practitioner. They may modify the disability amount. They may modify the drug plan a little bit, or many of you probably have flex benefits. They'll tweak around with option 1, 2, and 3, and it becomes a little bit different. And lastly, I would say, as I travel the country and meet with all kinds of clients, the danger of latching onto averages is a bit of a fool's game, because that's not the way insurance works. If you drive into a light pole 3 times with your car by yourself, it doesn't matter what the average is. Insurance is renewed at a group level, and there's tremendous volatility in the small, mid-sized market especially. The overall average may look a certain way. But you raise a really good point, because we're not the ones driving and promoting things like annual maximums. It is what employers, in the absence of knowing what else to do, will sometimes choose that. Mm-hmm. We're actually trying to reduce that prevalence and incidence.
Yeah.
Bobby?
To add, a little bit around the Quebec model, there's always nuance, right? So imagine that in Quebec you are an employer that has a very expensive plan year, right? You go up to your renewal and it's going to be really expensive, and you have 2 choices. Offer a benefit plan that matches what the province has mandated, or don't offer a benefit plan at all. And I worry about the path in that second scenario, right? Like, if things are too expensive, at some point it just breaks. So what we're trying to do with all of these systems and these due diligence processes is create a reasonable middle path that's not a sledgehammer, that's more of that scalpel, that shows value, that is reasonably priced for plan sponsors, that keeps benefit plans sustainable into the future. If it's too much, then our plan sponsors won't be able to offer this anymore. It's a optional thing for them. They're not mandated to have this.
All right.
Yeah.
Thank you, Bobby. Martin, David, thank you very much for your perspectives. I think we're at time right now for this panel. Thanks, everyone, for your questions and engagement.
Thank you.
Good job.
Thank you.